We do have one more guest with us this morning, Ken Ehlert he's the Chief Scientific Officer from United Health Group. Ken's going to be covering a payer's perspective, pricing and health economic drivers that incentivize development and investments. Ken, thank you for joining us this morning.
Sure, Carl, thanks. After thinking about it a little bit, we decided to change the title here. The conversation that I have with people all the time is, especially from drug companies, is how do I get more investment into the chronic disease space? And I think, as I've talked to them, and I've talked to most, if not all, that keeps coming up over and over again. And I think that actually that's not really the question they're asking. The real question that's being asked is, how do I take my existing model and apply it exactly as is? What can be done differently to make sure that my model will work in this area of chronic disease? And I'd like to actually take just a few minutes, not replicate other things that have already been said, but actually try to just bring a little bit of a perspective to it that to try to open up the discussion a little bit more. Next slide. So when you're thinking about a payer, I think what usually comes to mind for people is an insurance company, but I'd like us to broaden that out a little bit. That's federal government, state governments, employers, individuals. Payers are anybody that's actually paying for that cost. And let's just focus in on the employer group right now by themselves. So if I take over the last 20 years or so, the median income in this country really hasn't changed at all. It's stayed flat. Healthcare costs have gone up. So when you think about this from an employer perspective, we're a large employer. For our employees, our total cost of employment is actually continuing to go up. Almost all of that cost of living increases and things like that are being eaten up by the increase in healthcare costs that come with it. So when we talk about the existing model, when we talk about new models, when we talk about all those different things, one of the things that we got to start thinking about a little bit more is, does the model actually fit what chronic disease is? So when you look at this as a payer, so as an employer, of course, we want to intervene in the disease as early as possible. Kristen talked earlier about pain. Pain is what brings us into the system most often. That's how we actually get there. Pain in our body lets us know that we need help on some issue. When we actually go through that, we want to intervene early in the process. Every payer wants to intervene early. When we intervene early, the clinical cost of doing that, meaning our actual outcome that we see, do I get debilitating disease or am I able to keep functioning in life? That outcome is improved. The financial outcome as well is dramatically improved. It's way cheaper to actually intervene with somebody early in their disease state rather than waiting until late stage disease. Next slide, Melvin. So let's take one that folks are aware of. I'm not going to talk about diabetes, but rather obesity. My wife and I happened to be married in 1990. We're still married, 7 children later. We did not cause the obesity problem in America by getting married in 1990. But this chart that's up here right now, when we look at this by state, the color coding there, we had to bring in new colors as we actually went to where we are today. So we started out with most of America in a state close to 10% of the adult population being obese. And today, we're at a state where about 30% of the adult population is actually obese. I can't actually look at that and say, how do I bring the existing model into that world and look at a $10,000 drug therapy, which is not that expensive, but a $10,000 drug therapy for 1/3 of the population of this country. That would be a $1 trillion market. As already been pointed out, that would increase the cost of everything by about 1/3. And when you think about the total cost of employment, not only would we stay flat, we would actually have to have people start taking a decrease in their real income that they actually bring home. So when I look at this, what's actually happening inside of here? Humans don't change that fast from a biological perspective to say in one generation, we now look radically different from each other. Or maybe we do. Maybe we change a little bit faster than we actually think we do. It's not just inherited traits. So one of the things that we actually see happening inside of this is it's not just the obesity that's there that leads to, type 2 diabetes, or that leads to chronic kidney disease or heart disease or a number of different neurological conditions, those types of things. All of those sit inside of it. But it's not just obesity. There's other dimensions here that we could actually take. One of the things that it appears that we're on the cusp of right now, as boomers are actually aging, is that we're about to start seeing some significant downward pressure on life expectancy in this country, principally related to these chronic diseases. To highlight some of those things. So the answer is probably not to go and tell everybody, hey, you're obese, as an uncle just pointed out. I don't want the nurse to talk to me anymore because she told me I was obese. In reality, I'm not as fat as that guy over there, so I'm really not that obese. That's not going to be helpful for me to engage into an argument with him about whether he's obese or not. There are some other things that we probably can do, but it's probably not some sort of a public service campaign. In fact, Melvin, next slide. I'm going to actually use Lunchables here as the thing to point at as part of the problem, but Lunchables just happens. It's a metaphor, folks. It's they are not the only problem in this country, but Lunchables happens to be launched about 1990 as well. So what is it about Lunchables? Lunchables are awesome. My kids loved them growing up. We loved them on road trips. It allows me to let my child feel like they're getting real food. It lets me sort of take all the guilt as a parent and not spending time with my children and put that aside by dropping that into their bag on road trips. They're absolutely awesome. And so, how do we actually think about Lunchables? Even a former CEO of the parent company at Kraft at the time actually even acknowledged that the healthiest thing about Lunchables is actually the napkin that's inside. I went and got a Lunchable this last weekend just to confirm on this. There's actually not a napkin inside of there. So I'm not sure how that actually translates all the way through, but maybe they're not even as healthy as the box that they're actually in. What is really happening in this is there's a behavioral shift that's there. There's an entire machine that's out there that's pushing behaviors that are counterproductive to human biology. And that's one of the things that we need to think about. Everything that we try to do in health has got somebody on the other side of it actually pushing back really hard against what we're actually doing here. And it's not just what we eat. It's how we feel stress. It's the social media pieces. It's everything that we have going on in life is pushing back against us. Next slide, Melvin. So what do we have actually happening inside of it? We think in healthcare in terms of, a lab test or some biomarker that's actually out there. And we attach that to our therapies that we actually give people as well. So if I look at it and say, I'm going to have an indication for this drug that I'm bringing to market, I have to deal with this really complex human biology in the process. So we might start out saying type 2 diabetes and everybody that has a high A1C. And that will get us to an answer that says, maybe we should just put insulin in everybody because I can actually bring that A1C down. And yet, as we've done that, my apologies to Carl and to your company. As we've done that, we've seen the rates of heart, brain, kidney, liver, all those other things. We see those continuing to break, and controlling that glucose level really hasn't done a whole lot for us. So if I modify that to say, maybe we have a biology that really is complex and start looking at it and saying, earlier stage disease looks like obesity. And are there appropriate biomarkers that I should be attaching to that take into account things like the inflammatory load that somebody has, how the rest of the hormones in their body are performing, what's actually happening inside of their blood vessels, rather than a really simple measure like an A1C. Maybe there's deeper things underneath that we really need to be attaching to. The science would actually indicate that's coming out now is even things like fructose actually potentially alters how the immune system is actually functioning in our bodies. That's happening inside of a generation rather than just across a generation. So if we've got Lunchables to represent our behavior, in this category, we're going to call these Testables, things that we can actually attach to actually tell us, are we improving or are we getting worse? The progression of disease matters to us almost more than the disease itself. Our human biology allows us to actually deploy lots of countermeasures early, but if we can figure out when we are progressing, then we can start to do something about it. Melvin, next slide. Last week and a little bit this week, we've talked about this complexity and leading to new ways of actually developing out drugs. It's well known that it takes a couple $2 billion to get a new therapy to market with an indication. Maybe that can be 1/10 the cost of that. Can we use things, as Andrew suggested last week, AI, deep learning techniques that allows us to radically shrink the development cycle and actually bring a new level of precision to what we're doing. The second addendum I'd bring to that is, can we use things like pragmatic trials? Rather than having, as we just heard about, really clean patient groups that don't have anything else going on, they don't have any other therapies inside of them, maybe we need to expand that to be much larger trials, but done in a pragmatic way, so we can get a better understanding of clinically how should we and how can we actually use things in the process. I'll call these ones Drugables. So we have our Lunchables, our Testables, and our Drugables. And what we're trying to get to on this one is, instead of maybe one giant indication to rule them all, type 2 diabetes, maybe what we need to do is to break that and to leverage the concept of the heterogeneity that was talked about earlier. Break it into much smaller components and match together the therapy that we actually need to do with the biology of the person that we're actually trying to help. I would submit that if we can drop the cost of that development down and actually get the right markers to actually pull those things together for the right person at the right time, we can radically alter sort of how approvals happen, how clinical use gets adjudicated in the market, whether or not a payer is actually willing to pay for it. Melvin, last slide. So again, I'm just, only because I call them out by name, Lunchables is just a metaphor. There are lots and lots of different Lunchables out there. I enjoy them as much as anybody. But what I'd like us to be thinking about is, let's attach in these chronic diseases the complex behavioral items that we have going on with complex biology, and get to therapies that are actually not to treat 30% of the market with one therapy, but break that down so that we can treat segments of the market with a therapy early enough in the process that actually allows us to do something and halt the progression of the disease, so the stuff that Kristen talked about early doesn't happen. We don't need to have that. We need that artwork. We don't need to have more artwork like that. We need to arrest it earlier in the process. Thanks, Carl.